It's a pleasure for me to be here this evening, hosting a very special inaugural lecture. We come here at the back.
Can you hear me now? I'll start over. Good evening. Thank you. My name is Musa Mushavela. I'm the Vice Chancellor. It's a real pleasure for me to host this inaugural lecture, a very special one this evening. We've been waiting for it for a long time with Sudesh. And finally, it's also the last one for this month. We had 7 of them this month. And it's very exciting to see the vibrancy that comes with this inaugural lectures. All of you here also make it really special by being here. The attendance is great, and it's exciting for me to see as well. So I want to welcome all of you, students, academics, staff, emeritus, professors, visitors from outside, partners from industry, friends, family members, all of you, you're welcome. But let me take a moment to especially welcome the family of Sudesh. We thank you and your daughter for being here and the rest of the family. We very much appreciate she's in grade up, she's going to come to UCT. We really appreciate the support that you provide to him. He's really a shining star at UCT, and I hope that you will be, like us, share the moment of witnessing the journey that he's traveled to this point, which is simply a milestone. And obviously we expect more to come. Let me introduce the platform party. I know you don't know the dean. He is Associate Professor Lionel Green Thompson. He is the Dean of the Faculty of Health Sciences. And he's got the fortune of having to introduce Sudesh this evening, and we're looking forward to that. Let me also introduce Professor Stephen Roche, who's the head of orthopedic surgery, who will offer, he's tilting his head like, I don't know what that means. He's going to offer a vote of thanks for us and close for us. We've also got the Deputy Vice Chancellor for Transformation, Student Affairs and Social Responsiveness, Professor Eleanor Ramukondo, who is here. And we were supposed to have Professor Del Vashendi, but she dished us. Just go and lay down and take pictures and then disappear. She's sitting in the crowd. No, we can't trust you. But I do want to say, colleagues, that these inaugural lectures are really important. They're very important in the life of the university. They're very important in the journey of our academics. They mark a milestone, the point at which our academic ascend to the rank of full professor, which is really the highest rank that we all aspire to as scholars. So it is always worth the time for us to sit back and listen and really take full stock of the journey that our academic has traveled to get to this point. We are all here to officially celebrate with you as we all welcome you to the full professorate. We are here to celebrate the many decades of work where you have really put in a lot of effort and energy to achieve the kind of things that you've achieved, working across many disciplines, many sectors, really innovating and putting us as UCT on a global stage. We recognize the accomplishments and we are here to celebrate with you, Sudesh. I should also say, without taking too much time, because I know Lionel can't wait to get to the stage, that it's important for your students, for many other students, to actually witness this, because it helps in painting a picture of what it takes to rise to the level that you've risen to. The exemplary scholarship that you will demonstrate this evening is something that is very important for our students as well. What I like about these lectures also is the fact that they are presented in a way that is accessible to a diverse audience. I hope it is the case tonight as well. Because then also for my benefit I can understand what you're saying. I was with Sudesh at a lecture earlier this week in engineering, and I was told about how he betrayed them by jumping ship. And I said, no, he's not jumping ship, it's just connecting the dots. Multiple touch points. I don't know how they took it. But indeed, you know, we want to make sure that a diverse audience can access the presentation, the content of what we're presenting, so that we can showcase the work of our professors at a very high level. And for me, I get to see, as a new VC, I get to see what our professors are doing. And then I can also tell the story on the weekend. It sounds very sweet. And also, someone mentioned this to me earlier this week that I really appreciated, to say that inaugural lectures are also spaces where as academics we come to engage. Those moments after the lecture when you're sitting outside and you engage, we don't get many of those. Just like now as I walked in and I was just watching the interaction that was happening. It's so important that we have those moments. So you are also bringing all of us together to engage in a social environment, in a relaxed environment. And we are also grateful for that. And the same goes to the extended communities that are linked to UCT, of people that can also come to these lectures because they're just so accessible. So with that, let me vacate the stage and give Lionel his moment to shine. I will not be getting out later, don't worry. Thank you very much, ladies and gentlemen.
Good evening to all of you. And in the language of the Tamil people, Vanakkam. I want to greet especially now Sudesh's brother, who's online, Dr. Sudesh Sivarasu. And I want to greet his parents, Kalaivani and Sivarasu, who are at the hospital at the moment because Sudesh's father is in ICU on a ventilator at the moment. So I want to just ask us just to pause a little in solidarity with him in the ICU and with his family and extended family as they continue this journey with him. Thanks, colleagues. I also want to acknowledge Professor Matthew, who's online as well. You'll hear later that Sudesh regards him as a particular mentor. But I want to greet in a special way Gina this afternoon. Welcome to our faculty. It's very good to see you here. And to her mom, Abirami Kanipe. Welcome to the faculty. I think that what the VC says is so important that we don't always see you. And so seeing you in person helps us to see you in the work that Sudesh does. And we're really grateful for that. Because I think we always underestimate what comes from families in the supporting of our academics. A long way from here, in a tiny village called Veturana, near the city of the law, because when I looked for it on the internet, I couldn't find it. The nearest town is Vellore. In the Indian province of Tamil Nadu, a fifth child was born to a family of very modest means. The father of that household already declared that that child would be special. The family had an abiding commitment to education, which no doubt allowed that young child's curiosity to flourish. Sudesh Sivarasu was that child born to this family, and we snatched him away in 2011. And our story has changed forever. The fabric of our story here at UCT is now enriched by this golden thread which offers a completely new color to who we are as a fabric of society. We are pleased, though, that Sudesh's initial obsession with fire as a child was replaced by his obsession with mechanics and those kinds of things. But colleagues, we are here at the African continent. We're at the bottom end of the African continent, and I'm reminded, as I have been these last couple of days, about our shift into freedom and what freedom means, because freedom is really the researcher's essence. It's the elixir of research. If you don't have freedom to pursue, you might as well stay at home. And so I want to draw on the wisdom of Kwame Nkrumah, who, as the first president of a beginningly free Africa, said this: countrymen and women, he didn't have a woman, the task ahead is great indeed, and heavy is the responsibility, and yet it is a noble and glorious challenge. A challenge which calls for the courage to dream, the courage to believe, the courage to dare, the courage to do, the courage to envision, the courage to fight, the courage to work, the courage to achieve. And to achieve is the highest excellencies and the fullest greatness of people. Dare we ask for more in life? And today is a celebration of the fact that Sudesh is the quintessential response to that challenge, because all of those courages manifest in his research journey. All of those things that Nkrumah calls us to, we see in this career which kind of takes a turn at this declaration. But I want to just honor the fact that I visited the division the other day, and I have to say, people, it was my best day in the faculty for like at least a year. Nobody was complaining or Here was a group of young people making things work out of nothing at all. And the reason that I tell that story is because I left there with a buoyancy that came from the spirit of these young people. I mean, I was so fascinated by the tool that they're creating, which I think is outside in the displays there that you must see afterwards. There's a thing to measure cervical dilatation, where you put two little electrodes on your fingers, and you don't even have to think anymore. It will just do the thinking for you. So it's quite an incredible thing. But Sudesh's innate curiosity led him to pursue a degree in electronics and instrumentation engineering, and I can see this idea of crossing the line, so to speak. But a life-changing accident during his studies redirected him towards biomedical engineering. His journey in this domain was ignited by a powerful lecture by Professor Matthew on rehabilitation engineering, where he first saw how engineering could be used to change lives. Professor Matthew, another Matthew, you'll find a few Matthews in India. But this Matthew is from the Advanced Pediatric Center in Chandigarh. And he writes this for Sudesh in his reference letter for the promotion which he achieved in 2022. And I think I read it only because it captures what we're doing tonight, right? I co-authored a paper abstract with Dr. Sudesh Sivarasu entitled Creating an Ecosystem for Medical Device Innovation through Capacity and Capability Building. It was presented at the World Health Organization's 4th Global Forum on Medical Devices in 2018. But here's the kicker. This talk summarized that developing countries shared common challenges in medical device innovation and proposed an appropriate way forward through individual capacity building, institutional capability building, and organizational ecosystem building. The above, says Professor Matthew, summarizes the global relevance of Dr. Sudesh Sivarasu's research through FrugalBiodesign and its potential to impact South Africa and further to all developing countries. And I think that that's an important thing because the vision that I have with these young people in Sudesh's division and the connection with his spirit is really the essence of this professorship. But what drives Sudesh, and this part I got from notes that he said, I also asked him to send me a few pointers for this afternoon. And then it felt really bad that he sent me almost an essay, which I then had to reduce again. But he says that what drives him is this idea that creating a single medical device can save millions of lives. Not only now, but for generations to come. He views biomedical innovation holistically, understanding the need to integrate technology into its environment while addressing the pain points of stakeholders. I would be taking a lot of time if I tried to give you the sense of all of Sudesh's achievements. I think the one we celebrate most in the faculty at the moment is the Saatchi Chair, which has started this year and will last for a couple of years more. Saatchi chairs, for people who are not familiar, are the chairs that the National Research Foundation mandates to an individual to continue a particular kind of research. So his chair is in Biomedical Engineering Innovation. There are a number of awards across the years of Sudesh's career. Some of them are Exhibitors Awards for the Science Forum, the finalist in the NSTF, T.W. Kambula Research Award. He received an award from the UCT College of Fellows, the Young Research Award, and in 2017 was regarded by the Vale and Guardian as one of the 200 young South Africans to be watched. He's edited one book, written 12 chapters in books of others, and other books where he's been the co-editor. He has 54 reviewed articles, 6 of these written with Lazo Matthews, 62 peer-reviewed conference outputs. But this is the thing that struck me most, because often we struggle in an academic world where we only count articles. Here's a man who presented 66 patent applications for consideration. 27 of them have been granted. And in the one, which is a simple thing that allows young children to take their inhaler dose without having to time their breathing. Just a little finger movement allows them to give themselves the appropriate dose. If any of you have asthmatic children, you know that job. But I want to just read off the places in which this patent has been recognized. The European Union, South Africa, Poland, the UK, France, Germany, Turkey, the United States, and India. All of these countries have recognized this piece of work as worthy of saying, anybody who tries anything like this again, you copied it from somewhere. And I really want to honor that. And colleagues, in closing, and again, those of you who've seen Sudesh's work will know that his engagement with the NERCITA and the Department of Technology, Science and Technology, has resulted in a ventilator program that has reduced the cost of ventilation and responded quite dramatically to the challenges such as the COVID pandemic. I'm going to close, colleagues, with Thomas France's comment in his reference letter, kept confidential at the time of promotion, but now that the promotion is no secret, Professor Sivarasu's dedication to social responsibility is similar to his enthusiasm for teaching, research, and leadership. He serves on the EXCO of South African Young Academies of Science, Young Academy of Sciences, and is a member of the Global Young Academy. He has been very active in creating awareness for his research in the media, locally and internationally, thereby improving the public understanding and demonstrating the societal relevance of research undertaken at UCT. If any of you follow his division's Facebook page, you will see the kinds of things his students get up to. And there's an incredible video of what they're expecting tonight. Happy, ecstatic, interesting. But these are the things that his students continue to say about his work and their interaction with him. Professor Sivarasu's activities in outreach have contributed to increasing the attractiveness of science, engineering, and technology to next generation researchers. They showcase his research to school learners, particularly from historically disadvantaged groups, during departmental learner programs, divisional open days, and events organized at provincial and national level. Sudesh regards himself as a deeply faithful Christian man and recognizes that his work is a manifestation of that faith at work. He also emphasizes the importance of equipping students with the skills that they need for future employability. And that has become a central focus of his career. I'm not quite sure of his interest in all of the startups that his students create. I don't know whether he's buying shares in those. I see he's shaking a bit too vigorously. But this evening, Sudesh sits here. Professor Sudesh Sivarasu. Welcome to the stage.
Okay, let me start the proceedings by in the hierarchy. Professor Sivarasu, thank you so much for taking time to be here and being kind enough to start the proceedings. And a lot of people ask me whether Professor Sivarasu is actually going to be joining this inaugural lecture, because everyone knows it's 7th of this month, 7th inaugural lecture of this month, and 3rd in a row, Tuesday, Wednesday, Thursday. And Monday. Is it 4? 4 in a row, so I'm wrong. So 4 in a row, and he's still here. So thank you, Professor Sivarasu. Professor Lionel Green Thompson, thank you so much for such an amazing introduction. I'm not sure if I deserve it, but thank you so much for doing that. But it just kind of shows the enthusiasm that the faculty has in the work that we do. So thank you, Prof. Green Thompson, for your kind introductions, and also for unveiling many secrets. And Professor Stephen Roche, thank you for taking time to do my work at times, and especially Professor Ramagondo for joining this inaugural lecture despite arriving just yesterday night or today morning. So thank you so much for that. But most importantly, I would like to thank all of you for coming here. So without any further ado, let me just get going. Let me stop. Okay. Hope the slides move. All right. So the title I have chosen is Engineering Tomorrow's Medical Devices for Africa's Unique Needs. Kind of was an interesting topic because, at least to me, because I like to tell to my daughter, the one there, that she likes to call me a scientist. But I tell her repeatedly that I'm an engineer. So that's why, when she grows up, I didn't want to think her that I'm a scientist. I wanted to think that I'm an engineer. So I put the word engineering. Thank you, Adhira, for inspiring that. So, let's Prof Sivarasu mentioned, connecting the dots between engineering, the sciences, and humanity. Let me start with this. You will find it in all my talks. 2 out of 3 people globally do not have access to appropriate health technologies. And that's a massive problem. Why a massive problem? Because appropriate health technologies doesn't necessarily mean affordable health technologies. There is a massive difference between making it affordable and making it appropriate. You can make a technology cheaper by reducing the cost of the materials that are going inside making a device, but that doesn't make it appropriate. Our whole focus, our research group's entire focus has been creating appropriate health technologies, because when you create technologies that are appropriate, in long run, you make it affordable as well. So this is something that I would like us to observe, and I'm going to, I was listening to Professor Vegatlek's lecture on Tuesday, and I was thankful because they didn't ask questions after the lecture. But that's not going to be the case. If you don't, I'm going to ask you the questions. Okay. I just want to, this is something that Mr. Miladin Koluta introduced to me, the world map of map. He's in the audience. Thank you, Miladin, for showing us this map, at least to me. So the world map, it's a good indication of the areas of the map adjusted to the percentage of incidence. And this is something that I would like all of us to reflect on. Death under the age of 5. Let's see how this global map looks like. It's not a global map, it's India and Africa that's standing out. Every other country is skewed. Okay, let's see if that changes. HIV prevalence. Wow, it's now Africa, India, a little bit of other countries, but that's still bulging very hard. So there's something that we're not getting it in the map. So let's move this. So why is that a problem? It is a problem because when health is not appropriately shared, it leads to what is called overall multidimensional poverty. And if I can talk about it very rigorously, because we are in a state where we are actually spending a lot of money to get health delivered, and it leads a lot of families to go under poverty line because of one major health expenditure. And this is something that we need to be very mindful of when we talk about health in a holistic sense. So what are the other challenges? Okay, so here is something, a map that is actually a distribution that is distributed between non-communicable diseases and communicable diseases, and violence-induced diseases or violence-induced problems. And this is adjusted to disability-adjusted life years. I'm sure the members from Faculty of Health Sciences know this by heart. But just to highlight the concentration of all of these non-communicable diseases, communicable diseases, and violence-induced disability-adjusted life years are all concentrated in Africa. This actually proposes a unique challenge to all of us to co-contribute and co-create solutions that can actually work in this challenging environment. So let's dig this a little deep further. So this means that we should have sufficient people, sufficient technologies to address the problem, right? But let's look at how the healthcare expenditure is. We saw the map is being inversed now. The Africa and India is non-existent, almost non-existent, but just look at the amount of money that we are spending in healthcare in comparison to what's out there for the rest of the countries. We just saw the disease burden, now the health expenditure. And another important aspect, let's look at the number of physicians. So, if we take this into our account, this is the precise problem that we are trying to solve. We have the highest disease burdens in certain sectors. We have the least amount of investment going into healthcare, and we also have the least number of physicians who are here on the field to treat. This provides, or this makes a unique challenge to Africa. And we need solutions that can actually tackle all of these into account. So what is that solution? At least as an engineer, I would like to say that technology actually can bridge and transform healthcare from reactive to proactive means. How is that possible? Yes, it is possible because technology can basically, you might have seen how telemedicine has jumped into existence during COVID. And now suddenly a doctor who was able to see, a GP who was able to see only 10 patients a day is now able to see 10 patients every 10 minutes, or a patient every 10 minutes. That's fantastic. That's the way we could actually use technology to benefit the healthcare delivery. And that's something that we need to be cognizant of. And if we think about innovations, I also want to say that the moment we talk about technology innovations, we also need to think about another side of technological innovations, which is 90% of all innovation fails. Right? So there's no means of actually bringing out something new, then 9 out of 10 times that's going to fail. And now, if you take one step further, and if you think about product innovations, which is what we are interested in, 95% of product innovations actually fail, which essentially means every 95 cents that you invest in, of your 100 cents in product innovation, it's going to fail. We already have very little health expenditure, of which 95% if you invest in innovation, it's going to fail. So what is actually needed here? This is exactly what we are doing. This is a very favorite picture, and this is a picture that I would say plagiarized. I inspired from Professor Sivarasu because it was in the slide that we used together in the WHO presentation. When there is no ecosystem, this is what happens. This is a very classical thing you would see in the Indian roads. Everybody wants to go everywhere, and there is no means to get to the final destination. And this is exactly what happens. What is happening when we look at innovation systems? We do not know what our destination is. We are trying to go around and around, and we are just revolving around each other, not really focusing on our destinations. And that something needs to be changed significantly if we really want to reach the destination. And how do we go about it? Okay, UCT Research Context and Innovations Office, I know many of, we have a strong representation here. They give us a very standard guidelines in terms of how to create technologies and how to create medical devices precisely. And they ask a few questions. Where is it going to be sold? What is the risk classification? What are the regulatory requirements? They ask a very important question, who's going to pay for it? And it's something that I kind of pause here because I would like to make a very clear differentiation. Most of the medical devices are not, we assume that the patients are going to pay for it. The patients have very limited say on the medical devices that they use of it. So who's going to pay? It's the payers, or the hospitals, or the critical health setting. And this is something that we need to understand and we need to work with and work towards. Because it's not a B2C, where it's not a business to consumer, it's a business to business. So we need to focus on speaking to the right decision makers who can actually pay for your medical devices. So this is the sequence that follows from UCT RCMI documents, and there's a reference, you can always follow that. I would like to take you through some processes. Don't worry, there's no questions from these processes in order for you to design a medical device. What are all the things that you need to follow? This is something that we use in our course that we teach on medical devices, and just see the flowchart that keeps interestingly, annoyingly complex. And thanks to Dr. Harry Typhon, who put some of these slides together for our courses, who's in the audience. It just gets complicated because there is more than 1,500 steps one after another. And how do we navigate these things? I'm just giving you another model to show what it takes to develop a medical device. And if that is not easy enough, good luck in figuring out how to get your technologies out to the patients. This is precisely the problem that happens as a new innovator when you're trying to navigate the space. You're trying to solve a problem with the noble intention that you want to save people's life, you want to change healthcare delivery through your new technology, but you do not know how to actually reach that destination. And if you can map, the London Tube map kind of model, this will help you give you some guidance in terms of how do you trace your path to reach your final destination of taking your technologies to the people who need them the most. And this is one of my favorite slides, and this is something that I keep reflecting on myself, and I keep pushing this to all my students as well. There are two questions that I ask again and again, and I'm going to ask this again and again to me throughout this presentation, and you can ask it to yourself as well. The first question is, Okay, so what? So what? Okay, so what about medical devices? Okay, I can create a new device that will actually solve a person with disability to make the call. So what? Then comes the very important question, who cares? It might look like a very rude question, but I really feel like this is something that we need to reflect on for every innovation or everything that we're doing. So what and who cares? I will come back to it towards the end of my slides, because if you can answer the so what questions to who care questions, you would actually solve many of the questions that are unknown in between. Let's keep that, let's park these so what and who cares question for a while, and let's move a little further. I will introduce my concept of FrugalBiodesign. It's no rocket science. It's basically trying to say, put all of it together in an engineering design methodology so that you actually keep the person who's the most important in your innovation as the focus of your innovation. In healthcare, who's the patient, or who's the person who's most important? Patients? All right? Okay? So that's my 101 lesson today. Who's the most important person in the healthcare equation for innovation? Patient? Okay, let's see. Okay, this is a debate that I would like us to reflect on. Patient or the clinician? Because the patient is definitely a beneficiary of what comes out of an innovation. But does the patient actually have any say in the kind of technologies that get used on them? So, why do you keep the patient in the middle of your innovation? Whom should you keep in the middle of your innovation? Clinicians. It's a fundamentally challenging question, and I would like to be challenged further, because if you don't involve the decision makers in the middle of your innovation circle, you're missing the point. Right? As I started saying, it's not a B2C. We are not dealing with the consumers directly, we are dealing with business to business. Here, the other B is your clinician or your healthcare center or your payer. Right? Your insurance need to pay for it. Only then your cost will be covered. If we don't factor this in, we will be in the 95% majority. But we want to be in the 5% minority. That's okay. We'll be this side. How do we go about it? What is needed there? This is something that I kind of wanted to use this. Again, I talk a lot about my research, but I also want to touch a little bit on teaching, because Lionel, when you ask us for an anthropomorphic application, you ask for all the 4 portfolios: teaching, research, administration, and social responsiveness. And I see more often in inaugural lectures, we talk more about our research. We don't talk about our teaching. And I felt like we should actually a little bit touch on that, so that it kind of brings that academic side, the teaching side of it. Why I feel teaching is a very underrated tool for research, because we can use teaching in a very effective way. Let's see how my unit has used teaching for medical device innovation. And let's hear from some of our students. And I hope we can. Is it on?
which is what gynecologists use for operations, diagnosis inside the uterus. My problem was making that procedure a lot more mobile and accessible to women across Africa. So I solved it by taking kind of the existing system that's limited to the operating theatre, where the patient has to undergo general anesthesia, and making a mobile system that's a handheld device that's small enough and flexible enough to cause a lot less pain, because they don't need anesthesia outside the operating theatre in environments such as like the offices of gynecologists in mobile clinics. This can be packaged to a base.
business models, manufacturing.
If you have noticed, so long story short, what they are all saying is that the course is a great course and you should all try to. It's just one of those things, right? When you need it the most, the technology doesn't help, and we need appropriate technology. Coming back. Right. So one of the key outcomes of these the courses that we teach is that the students learn. Enough of me talking. I just move nicely now. The students learn how to interact with clinicians. They learn on what languages to use, what lingos to use, what kind of terminologies to use when they are interacting with the clinician. And this is something we emphasize very strongly. At the end of the day, when you're creating new technologies, new innovations, it needs to be safe first before you're talking about bringing efficient technologies. And why does it need to be safe? Because a new innovation or a medical device, the first priority is it should not introduce new risk to the patient. And then it doesn't, how do you quantify that it doesn't introduce new risk? You need to classify it on the basis of our regulatory bodies and make sure that we are in alignment with our regulatory body in our geography, which is like SABRA, CE, FDA, whatnot. So just to give you a highlight of the 100, okay, and another trivia question, do you know how many medical device types are there out there? Anyone who says that will get a Dairy Milk chocolate? WHO classifies there are 10,000 different types of medical devices. Okay, that's not the thing. And then when it is further subclassified, there are 200,000 divisions of medical devices. Right? This is just a background. We need to understand that the moment we talk about medical devices, we think about robotic surgery, we think about MRI units, machines, etc. But there are simple things: the scalpels, the gloves. You know, the surgical, the scalpel is one of the oldest patented medical devices for the ones who use it. You know, there is a whole variety of medical devices out there, and of which, 35% of these medical devices are the low-risk devices or class 1 devices categories. 53 are in the medium risk or in class 2 devices, and the rest in the class 3 devices. We need to make sure that when we are creating new technology, we need to figure out how do you ensure that you fit into those brackets. And for which, why do we need to follow this? Is to ensure that we understand that it's first safe before being efficient. And there are requirements, no test questions from here, so further requirements of ISO 13485, ISO 9001, and ISO 14155 that one would need to be aware of if you're going to be creating medical device innovations. Okay, so what? Who cares, right? So what? And it's a question that is glaring at me, so I'm going to keep responding to that question. So what? We try to use many mentors program, both Dr. Hari Kaithur and Dr. Mark Thorty are here, which actually helps our innovators to come out with bridging courses that will help them in skills and create tech solutions which we can use it as a live case study to train our students. What did we do with that? This is Harry's favorite slide here. We figured out there are multiple valleys of death in innovation. So if you're just thinking that there's going to be one valley, there are multiple valleys, and we need to have a good way of navigating these valleys of death. One of those valleys is the quality management system, right? Why? Because you need ISO 13485, you need 9001, you need to be GCP certified, you need to be GMP certified. We are an educational institution, we are not supposed to be, or we cannot afford to do this. No, it doesn't matter. Whether you're an educational institution or a corporate, you still need to do this. So, our center becomes one of the first academic center on the continent, thanks to, I am assistant with Dr. Mark Thorty, who's here, to get ISO 13485 certification, which is under review, and we are in the process of getting SABRA medical device manufacturing license as well. Because this is one way you actually prove that you are in alignment with the global standards, because at the end of the day, you cannot compromise on patient safety. And this is something that we are establishing within our Biomedical Engineering Research Center. And then another important thing, cost to develop medical devices. Again, it's a very depressing slide. A simple medical device can take about 600,000 rands, $600,000 for the connection, small connection, $600,000. But a complex medical device can take up to $20 million. But that's not the easy part, that's not the fun part. It can take about 7 years to 14 years to develop and certify these technologies. Wow, okay, so that's a lot of problem, right? So 14 years is too long. $40 million is too much money. Okay, now talking about money, I would like to thank all my sponsors. Because without you, I wouldn't have been able to achieve anything even remotely, right? So thank you to all up there. Social media was these posters. I also would like to thank our partners in innovation because it's not done in isolation. It's something that we actually go deep into and we kind of go step by step. From the National Research Foundation and DSI, which kind of funds my salary through Saatchi, to Mercita that Lionel was mentioning, to TIA, which has funded many of our research initiatives. One of our major funders, if you look at this whole equation, the center of this whole funding comes from UCT RCNI, the Innovation Tech Transfer Office, and I want to do a big shout out to them because they have supported a lot of our innovations. Thank you, RCNI. I also want to highlight that it doesn't stop there. It's not only about funding the research, it's also about taking out there. So our collaborators Innovation Hub, Dr. Sudesh Sivarasu, and his team is also here well represented. There's a stand out there that you can have a look. It's just to say, it takes not a village, it takes an ecosystem to grow an innovation, right? Let's grow that ecosystem, right? And this is something, inspiration struck to me after the Tuesday's lecture, Prof, and I made my team work like anything. Because I wanted to condense my lecture, and I was sitting at 150 slides. I didn't know how to do that. We still have 150 slides. The point is, I wanted to see how we can condense the various innovations that we're doing. And I started saying, can I put it disease categories? Can I put it economic category? Can I put it racial category? No, we are working on almost every human part of the body. Then, inspiration stuck head to toe of innovation. What have we done? Head to toe of innovation. Let's look all around, and all these are the innovations that we have done. Right from something that goes onto the scalp, right to the bottom, something that goes onto the feet. We have done innovations all over the human body. Right? I would like to use that as a moment to pause, and then I take my next slide, which is a big marathon that has been going for many, many years. That's in the shoulder space, and no wonder, I'm still surprised that Steve agreed to give a word of thanks despite working with me for 10 years and the torture that we have given him. I kind of emphasize on creating true and equal partnerships, because we can create true partnerships. We not often create equal partnerships. And it's something that I would like to emphasize that for young innovators to zoom in and look on creating true and equal partnerships. Why? This person here, Professor Stephen Roche, met me in one of the dissection rooms up there, and 2013, he said, I have got a problem and you need to solve. You're an engineer, you should be able to solve this. So let me try. The relationship started there. I couldn't apply for funding because of my non-residential status, so Steve used to apply funding on my behalf. Again, emerging researchers, it's okay, he can apply and we can still spend the money. Don't worry, you still have to write the grant. So Steve wrote multiple grants and he got multiple awards, funding awards, and that led to us starting our orthopedic research, orthopedic biomechanics laboratory. What did we start with? We started with first principles, science to science. A terminology that I only learned like last month in an ASAP meeting, where they kind of figured out or divided sections based on science to society, etc., etc. I felt science to science was quite good because you do science for the sake of science. And this is something that we did without even knowing that it was science to science. It's very catchy, I'm using it now. But science to science, we wanted to go to the basics, first principles on where the problem is. Steve wanted to design a new prosthesis. But what's the problem with the existing prosthesis? What's the anatomical relevance of existing prosthesis? What is happening? Steve's problem was, he said that the existing prostheses were designed based on Caucasian population. It may not be relevant in our African population. Do you have any evidence, Steve? No. Can we create that evidence? Yes. What did we do? We created the first South African population data set, and we did a comparative study. I think Dr. Rupam Dey is here. You can put up your hand, Rupam. Rupam Dey and Dr. Wumi Inyang together, they started their journey together, and they figured out various aspects of shoulder anatomy that are quite different to the existing standard data set which is used for designing implants, which is the Caucasian data set. And what it actually led, this is part of Rupam's study as well, what it actually led is the figuration that we are anatomically different. Not only physically different, we are anatomically different. So, what does that mean? When you try to plug in something that is designed for elsewhere and put it into your body, it's going to fail. Right? Let's try to see how we can actually address that problem. So what did Rupam do? He came out with his own total shoulder arthroplasty, which, the problem with the shoulder implants were rocking horse effect, and Rupam tried to design an implant that was actually compensating for the rocking horse effect. And then similarly, Jonathan, who's another PhD student of ours, did a reverse total shoulder arthroplasty, and both of them together came out with some massive recommendations. Rupam came with a new implant design, but Jonathan said, you don't need to design a new reverse shoulder arthroplasty, you just need to position it. You need to position it differently. He used 70 different placement locations, and then he said lateralization would actually solve many of the problems that you're actually presenting. So, Jonathan's paper, he created a framework paper, and which is one of the most highly cited papers in the reverse total shoulder network. It's kind of a landmark paper in terms of deciding how to position surgical implants in surgical theaters. But then that's not sufficient. We need to actually prove that it is safe. That's okay. We'll come to that. I think I got the slide mixed up. There's another study that was done to understand how Steve randomly puts latissimus dorsi in a surgery. We wanted to educate the surgical procedures by seeing what would actually be better in terms of surgical positioning. And then what it actually led is identifying suitable locations for surgical fixations that will lead to better outcomes. So if you want more range of motion, if you're an patient who needs more range of motion, where is the point that you need to fix it? If you need more, what is the best compromise location, etc., etc. So this kept on going, and again, the question I would keep asking is, how do you prove it's safe? That's where Leanne's work comes into play. Leanne is also here in the audience. So Leanne designed one of the first African ASTM test rig for shoulder implant testing. We want to test these implants, but we don't have facilities on the continent to do this. So how do we do it? Let's create the test rig from scratch. That's the standard that we need to follow. Let's create the test rig. Leanne did it as part of her master's, PhD, sorry. Leanne completed her PhD recently, and she actually came up with an outcome of more than 500,000 cycles, 700,000 cycles of testing of an implant. And this was surgically implanted by surgeons with implants that were locally designed by our local data. And all of this show that despite all these rigorous efforts, we are actually in line for actually making patient-specific, population group-specific implants, and we haven't done that yet. So it's quite important that we actually segregate that we are anatomically different, and we try to address that underlying, not an issue, it's the underlying feature that we will need to embrace through our innovations. Scapular fracture devices that Haptamu has come up. I'm including a lot of slides from Steve's inaugural lecture as well. So, because the work that we have done together, this is a scapular plate that Haptamu developed for gunshot survivors. And just to quickly run this video. Once we get the scan is 3D modeled, then a fixation is put on, heat map is generated on basis on where the usual problems or usual fractures happen, and then those implants were designed locally, manufactured locally, and tested on cadavers. And the results were promising. Again, enough of Steve, let's move to others. Another from orthopedics, cervical fracture. Professor Kruger from neck and spine unit. We designed this first portable cervical traction device that can be slided under a patient's bed, and you can still do the traction and relocation for the patient together. This was done with our master student Tertius de Villiers, and it's one of our recent patents. Like we filed for a patent last year. It was a PCT that was filed this year, and this technology sounds very promising because there are no existing technologies out there that can actually do this. Completely automated cervical adjustment to relocation. Going next, we don't need complex technologies to create impact. Sometimes it can be something that actually addresses the most simplest of the problem. The simplest of the problem that I'm going to be showing today is something called an open ptosis crutches, which is an open source technology, which also happens to be South Africa's first open source technology, open source medical device technology. And there was a long process for us to get that approval. But it's something that I'm really proud of because it's not the complexity of the solution that matters. It's the appropriateness of the solution that actually matters. You might have heard about a condition called myasthenia gravis, where patients suffer with drooping eyelids, and it cannot be surgically fixed. So how do we address this issue? The patients themselves pull their eyelids this way, or they use a cap to pull their head backwards, so that they can clear the eyelids or the visual axis so that they can see. But it doesn't happen that, by doing that repeatedly, they end up having cervical compression. So what can you do about it? That's when, it was many years ago, that's when Google glasses were introduced, the fancy Google glasses. We thought, why not we use that to something similar to that to actually solve this problem? Ptosis crutches were born. A simple add-on that is fully 3D printable, that can fit to any glass shapes and sizes, that can lie in the eyelid crease, and that can elevate your eyelid crease throughout the day. You can pull it, push it down, pull it, keep it as you like. Why it's such a big innovation, at least in my view, it's not because it has made money. No, it has not made money. What has it actually made? It has actually been used by hundreds of users, and as of last week, 17 different countries. This is the only solution that's out there. We could have very easily patented it. We didn't patent it. We let it in open source. We got formal approvals from Litmo to put it in open source. And because we wanted to create the impact, sometimes impact speaks louder than money. Not sometimes, all the time. I think that applause needs to go to those two ladies there, Megan Findlay and Jenny Heckman, who were instrumental in getting this. Jenny is the clinician, and Megan is the master student who worked on this. Currently being used in 17 different countries. I'm not sure how many such technologies we can create in the future, but this is something that we are very proud of. Okay, what's next? Okay. As you can see, you can count as we go round and round and round. We'll be reducing the time between myself and dinner. So, TV. Here is a cast device. Raisa is here. Raisa in the audience. Okay, Raisa is there. So Raisa Ismail, one of our master student, is developing a portable mini cast system. You have to go into a room-sized room, cough into that room-sized room machine, and get TB samples to see whether the patient has TB or not. That's called the cascade impactor. But Raisa has designed a little coffee cup like system where one could actually cough into this coffee cup and take it with them throughout their home, with their home for 3 days, come back, the culture is grown, and then you can actually go into diagnosing that. We want to fast track the lack of diagnosis of TB through innovations like this, and this is being worked with Professor Keithan Hida from the London Institute of Pulmonology Unit. Another innovation that I want to showcase is total biopsy device that increases the biopsy yield that basically, instead of doing a blinded procedure, you could actually know where you are in the pleural zone. The pleural area is a negative pressure zone, so once you get there, you're alerted about you're in the zone, and then a biopsy, continuous biopsy is taken. So anything over 1 millimeter square is a goal for a sample, for a biopsy. And we can see already there's large size samples that we have been able to get with a simple device like this. And this is something that would be very useful for South Africa and rest of Africa. What are we doing next? EEG, Fazai, are you in the room? I'm just picking a few, Fazai, in the last row. Okay, the EEG headsets. Okay, one problem with mental health, with epilepsy, is screening them for epileptic care. Okay, why is this an African problem? When you go to the clinic, you're in a well clean shaved space, the electrodes are put up. It's great. You can actually diagnose whether the person has epilepsy or not. What about the patients who don't come to the clinic? What about the patients in the community? How do you get them to screen whether they've got epilepsy? Because 70% or more of the epilepsy problem is in the rural areas, and we don't target them. And we actually see that is something that we haven't actually figured out. So the other problem is that tight curled hair of African ancestry is something that is challenging. It's not just an African problem. You might want to look at my daughter's hair as well. She has also got a tightly curled hair. This poses a challenge that the electrodes don't sit on the scalp. It pushes the scalp, the electrode out of the scalp. This is a challenge when you are trying to take something into the community that you need to be addressing. You need to figure out a solution that can actually sit closer, and if you are trying to Africanize or localize the solution, you need to actually factor that into account. And I don't want to go into the Kenyan example where white headsets seen as a symbol of death, so we changed the headset color. Another appropriateness, white technologies need to be appropriate because that community sees the color white cap as a symbol of death. So we were not aware, or the team was not aware, and that ended up being a problem. So all that we did was change the filament color for 3D printer to make it black. It's appropriateness at its core, because we need to factor all these into account. Okay, what's next? You see, ventilator solution. Okay, we are one of the 100 other companies that developed ventilators during COVID. We are not ashamed to say that. But what's different about us is that we actually factored this ventilator solution. We used this ventilator solution to develop multiple other solutions that can be based out of a ventilator. So this is a fully software-driven ventilator that can be updated for a future pandemic. If the future pandemic requires a high-flow nasal oxygen system, this ventilator can actually adopt to do that, right? And not just that, it led to a whole array of ventilation solutions or related innovations that came out of this ventilator project. Again, thankfully funded by Masita. Okay? And all of this, I can go in detail, I can do a lecture on each of these, but that's not the point here. It's about what we have and how do we use that to build our ecosystem. Here we built an ecosystem of which one of the technology, Inspire, stood out to be a company. There, right? We'll talk about that. And as part of that exercise, a textbook was published, again, made open source, open science, using all the keywords. So, open source textbook for anyone who's interested in medical device innovation, published by UCT Press. And then we also created a lot of solutions that ended up not only used in COVID, but also ended up being used beyond COVID, which is in PD, right? Let's see some examples. The National Ventilator Project, I'll talk about it a little just now. The National Ventilator Project, 20,000 ventilators were made, millions of lives were saved, and I think that served my purpose, right? Because we were part of a small part of that journey in testing it here. Not just this, there were about 6 other solutions, ventilator solutions that were SAPRA approved for emergency use, all tested in UCT and approved by SAPRA. So it was a protocol that we used for the National Ventilator Project. And this is something, again, appropriateness. I want to say, this is Steve, the peak of pandemic. He's working in the foyer of anatomy, trying to test the Ubuntu booth. All that he's saying is, he's mocking a situation where one will have to do a sample, a deep sample, and the length and the width of your hand gloves, and how it's going to be cleaned, how the sample is going to be taken, how do you clean after the sample has been taken, and how do you retrieve the sample. I don't know if Steve remembers this. I was shooting it so that we can actually train our field workers on this. This is something that we created for reducing the usage of personal protective equipment during COVID. Never did we know the demand is still high. During COVID, we installed only 3 booths. We call that the Ubuntu booth. We installed one in British Care Hospital, 2 in Bishop's Plain Public Community Hospital. Never did we know that there was going to be an increased demand post-COVID for TB, because now a lot of people, a lot of units are just ordering these units for TB testing. And this is something, again, if you can factor the essentials, you are solving multiple problems using a single innovation. Simple solution that you will see again, a Wiser face protective mask that was developed as part of COVID. I like this example because not that it's less than 10 rands to make it. That is not the problem, because the government was paying 75 rands for procuring one of these. We made it less than 10 rands, but that's not the actual problem. What we're excited about. What we're excited about is where we made this. Can you figure any name? People there? Of course, the blue shirt is me. If you haven't figured out, I always wear blue shirt. My daughter complains me of that. But the other 2 ladies are there. Okay. Thanks for guessing. Salome Maswimi. Yes. Professor Salome Maswimi and Tracy Melody. No, not Tracy. Tracy Adams. So, both of them. Why? Because they were instrumental in testing these devices and taking it into the hospital. Right? Salome is out there. So, they were instrumental in getting these technologies out there. And it's never our innovation or my innovation. It was our innovation. It was a collaborative effort to begin with. What's so big about it is because 60,000 of these were made during COVID. The peak of lockdown, all of us had permits to travel, and we hired local printing company. We hired mattresses. Mattresses were not, nobody was buying new mattresses. The mattresses were at dead cheap rate. We bought them. We got it cut, laser cut in the profile that is needed. We used stationery companies to print these things together. We employed unemployed women to make these visors, put them together. We got it certified, approved by SAPTA, sent it to clinical use. All this happened in 2 months' time. I'm very pleased to hear Renu and Mr. Salaki is here, because they were one of our primary funders to take this technology out there. I don't want to say how much they paid. They gave us a lot of money. But it is essential that it's not that money that is used into feeding research and development pipeline. It was a circular economy problem that we were solving. A lot of people were getting employed because of this. A lot of jobs were created, and still impact was created. When you're stepping out, have a moment to go to our exhibition booth. When we have seriously, so that you can thank Mr. Salaki and Mr. Reno, Dr. Reno Mara later for the funding. But what again I'm saying is it's quite important that you can't do it all by yourself. Understand that. You're not there to do it all by yourself. You are here to collaborate. Make sure that you understand your weaknesses and work with the people who know what they're doing. How did we distribute these 60,000 units? Or half of which were distributed through gift of givers. We gave it to them and they gave it to the world. Right? So, not ashamed of saying that, because you create impact. Another important journey, learning that I've got is, fix your stakeholders' pain points, or they will soon be in rush. Or you'll be in the crowd 90%, which is fine. I also want to say, we run some workshops every now and then, and these workshops are not necessarily in our field of expertise, and we like it that way because it challenges us. And the one that we did last time is called Contextually Medical Design, and we're doing one more in November. And this was to deal with gender-based violence. And how can we innovators come together and address or support gender-based violence issues using technology? The new workshop is going to be on gender-based violence and interpersonal violence. If you do not know, interpersonal violence is the third highest cause of death in South Africa. So we need to be aware of that and thanks to the support from our international collaborators who have been actively contributing to these workshops through their expertise and also financial means to take our students and give them the exposure that is needed. This is something I'm really, really proud of. Not that I'm not proud of what I said so far. This is something I'm really proud of. There's a very big saying in our culture. It's okay to lose to two people, right? One, your own children. Yeah, it's going to take some time, but she's already. The second is to your students. It's absolute honor. They made this as my biggest achievement. You know where I'm going with this. Right? Fruits of innovation. I want to highlight the fruits of innovation. And this is again after your Tuesday lecture. We came out and started. We had so many caffeine and coffee, and the creative juices started flowing. We wanted to showcase all our innovations together. We designed. Joel was the guinea pig for this. That he put together this fruits of innovation. What is this fruits of innovation? The innovations that have actually rooted to become a startup company, right? And I'm going to take a brief journey of each of these startup companies. So I'll keep it brief. You can trust me on this. Okay, where is this going? Rescrab, a hand exoskeleton that was developed with some of the most brilliant innovators out there. Mr. Gavin Jones, who acted as our CEO, Mr. Michael Awood. Ever since I knew him, he's never left us. Thank you for that. Mr. Asian Dritzal was the student who was working on this project, and Dr. Lester John, who helped in conceptualizing the solution together. One of the best solutions that we have developed. Let me say one of the best solutions that we have developed, because it's an exoskeleton that can help you write. If you know what stroke rehabilitation is, you put your hand, your handwriting therapist will put their hand on your hand, help you write. We created a robotic exoskeleton that can read on your behalf. That was tracing a path, tracing a triangle, tracing a circle, all that. Then we also made it, you can see the age of this technology by the mobile phone model that's being used. And it's a fantastic technology. I'm starting to sound like Trump. It's a fantastic technology. Never did we realize that this technology is never going to take off. What happened there? It's something that I'm very proudly showcasing, that I failed, and I'm okay with that. Why? Because we did not realize that it's not always about technology. When an engineer talking about technology, it's not always about technology. It's the interface of technology and the human being out there. So, what did we fail to understand is, will you put your hand in there? Yes, as an engineer, I'll put my hand in there. Think about you as a patient. Will you put your hand in there? You are brave-minded, so you will put your hand. Will you put your child's hand in there? I will never. That's exactly was the reaction that I was getting from the users, because they felt it looks like a Frankenstein machine. Right? The other side of the story is the clinicians didn't want to use it. Why? They felt automation is going to take their jobs away. The center of your innovation, who is there? In this case, no one. Neither the patient nor the clinician. What does that mean? We got a lot of awards. That's great. We showcased in the parliament. That's fantastic. But innovation thrives on demand, not on push. So it's absolutely okay. It's okay to fail, but provided you learn what comes out of it. What comes out of it is our fruit number 2. The fruit number 2, going back, impulse. Again, I like the technologies. I'm so proud of this slide. You want to see it over and over. It's not the creative best yet, but it will get there. Impulse, a startup company which started at the failure of our previous technology, but then they did something that others didn't do, which is they learned from the best, which is failure. Not to keep away from people who make the most important influence. That's Impulse, and I'm going to call out Impulse Biomedicals. Will you please stand? Hala Lucas and Gokul Nair started this company together. Okay? I'll tell you a backstory, Kutti story in Tamil a little later, but it was a forced incident. They won multiple awards. They raised a lot of money through awards. If you do not know, you can win a lot of money. I'm talking in the orders of millions through awards. Right? Don't only look for grant money, also look for awards. That equals awards. So now we apply for every award out there. This is a solution that I'm going to ask the VC and the dean to use this. Again, why I'm showcasing this is it's a simple but effective solution, right? Let's see if it's simple and effective, right? Vice Chancellor, do you mind using your pinky finger and trying this? That's something that I learned from JC. Okay? Use your pinky finger and try to use the inhaler. That's precisely the amount of strength that a child who's 5-year-old will have. Pinky finger and this together. Now use your regular finger. Oh, it's a reality. So JC and his team came out with this innovation where you can actually put this together, assemble, knock on. The Chancellor, I would like you to try it. No, away. So they've done a very detailed review about this, and they made child-friendly units as well. And this is a child-friendly unit. Thank you. I'm seeing this for the first time. This child-friendly because we don't want the child to break it and open it. So for the child, this thing to put together so that the child cannot open it by themselves. Thanks, Dustin, for teaching me how to use this. Again, away from students. Right? Why it's important that we solve this problem is now my child can actually use this inhaler if she wants to. She doesn't need to depend on for an adult to help her use this. Where is this leading to? You now have users, clinicians who are now happy about using this. I can see it on the Vice Chancellor's face. You can. The kids are happy because they see cartoon pictures. They are happy about the collectibles. And I saw Frank Shaw came all the way from New Zealand to attend this lecture. Frank Shaw, it was your idea, Frank Shaw, that we used cartoon characters. We acknowledge that. Thank you, Frank Shaw. We were thinking as a biomedical engineer wanted it rusty. No, Frank Shaw said if you want to put it to the kid, make it playful. That's where it started. So what has that led to is, you don't need this video, it was demonstrated live to you. The inhalers can be easily replaced with any size inhalers can be put in, and the force is reduced from what was 40 newtons to now 8 newtons. A child of 5 years and above can actually use this. That's really a good effect. What we also got on top of it is multiple patents that Prof Thompson was kind enough to read out. And that's amazing as well. Right? It helps in ad-hom promotion. What happens next is ZiviPen, reloadable adrenaline auto-injector that the same team developed. So if you know EpiPen, ZiviPen, it's similar to that, but the only problem is EpiPen are expensive and you don't get it in South Africa that often puts enough shelf life. They came up with a solution that can actually help with the same reloadability with a quick action. So you can basically go in, fit, and get the auto-injector of epinephrine working. And so this is the training unit. Somebody who's brave enough to use an adrenaline auto-injector, it's here. You can try it on your guys. Just to show you that it's a real thing. Pulp fiction moment. So, what is that led to? This reloadable auto-injector is now completed first in human trials. The result sounds positive, but they don't want to declare it yet. So we're waiting, hopefully, we're waiting that they will release the results soon and get better investments. But that's, again, multiple patents, that's beautiful, always good to have. But we can use it in multiple cases, not only in academic, we can use it in multiple other cases. It has gotten several certifications. All this is great news. Clinical study is great, so we've got publications of it. So the research office is happy, all that is going well. But again, a lesson from here is following instinct. Why following instinct? Because I don't know if Gokul and JC knows, but I think I've mentioned it to them, that they were forced to work together on this project. Two different innovations, they were forced to work together because adversity, we didn't have money to pay two salaries. We had money to pay one salary, which was divided into Gokul and JC's salaries. They were forced to work together, and they came out with this brilliant innovation idea of combining them into a single innovation company. So, not having money is not always a problem. So, we are in deficit. It's okay, we'll figure a way out. Fruits of innovation, that's melted. Where does it go? It goes into the uterine cavity. What does it do? Edmund seems to be a very popular person. All the CMD communications department likes Edmund. They say because all the awards that he has won recently. Just to mention, Edmund was one of the first UCTian to win the Africa Prize for Engineering Innovation last year, and second South African. And last week he won the SAP Developmental Award. I said, you can make money with the awards? Yeah, he made 700,000 rands cash prize with that award. Promotion to Vaccinated. This is the problem that he's trying to solve. Bulky existing hysteroscopic device, he wanted to take it to the field of care. How did he do it? He came out with a brilliant innovation that actually allows you to reduce the need for anesthesia. That's why you need to go into surgical theaters, do the whole procedure under anesthesia. He basically got that away by making the entire tip less than 4.5 millimeters. What does it do? It makes clinicians, nurses to actually use the technology. So this is the technology. It's being demoed out there for you to see, because we're not talking about theoretical stuff. It's real thing. It's a real deal. And let's show how this actually works. It's a tip, less than 4.5 millimeters, and it will actually show you the precise use case that we're talking about. And the video. You go into the uterine cavity, that's the smaller cavity. You go with the flexible tip, you're able to go see, navigate what you're wanting to do. And this can be done not necessarily by a specialist, it can be done by a GP, or sometimes even a very trained nurse can do this. So what was a barrier, the access to clinician, is now broken by the use of technology, that by that making it more appropriate to the environment where it's going to be used. Lots of awards. I keep forgetting all the awards they win, so including the change maker. That's Edmund's chair, we call it. Fruits of innovation, just two more. Higher health tech. Again, I started by Joel out there that we had. Joel, master's student, completed his master's with distinction, now he's a CEO or co-founder of a company. What did he do? He used a metadata solution to create created use for something that affects 12% of the population, of which 83% are undiagnosed, which leads to the risk of heart failure by 2.4 times and costs about $150 billion a year. What problem is that? Sleep apnea. Anybody who smokes in the room? We have sleep apnea. Right? So a typical use case for somebody to get diagnosed, they will have to go into the clinic, 5 trips to get diagnosed, and then 2 years from diagnosis they get treatment. That's a long story. Again, I want you to think about the multidimensional poverty for somebody who's getting affected in the very initial slide because of this. Joel, through his higher health tech, has created a solution that can do screening and diagnosis and treatment together, that one can actually take home and use it for sleep apnea. The last step, which is going to be officially launched today, the fifth test started, is using multiple innovations of ours, which doesn't have a single market, there are multiple markets. Michael Haywood, who's out there. Michael? Thank you, Michael, for staying with us for more than a decade. So Michael, with his co-founder, John T. who also does who's doing a PhD with Professor Sivarasu, who's also in the crowd. He's working on some very interesting ultraviolet irradiation solution for blood products. But on his startup, he's working on creating solutions like standard example you'll see when you go outside is a rehabilitation prosthesis. There is a smart walking cane, etc. I won't go in detail, but I kind of go back to my initial statement. You know that I'm going to the end of my talk, right? Initial statement, innovation needs an ecosystem. And what does the future hold? So there's a lot of apprehension about what the future holds in terms of health technology, especially after AI coming into play. To AI or not to AI, I think the answer is very simple. Our social media person, Vijaya, ran a survey a few days ago, and she asked what's going to be the future trend. A lot of people said AI is going to be one of the future things. Wearable technologies, advanced robotics, all these are, yes, people are thinking about these things every now and then. But I'm here to spread the message of hope that AI is here to assist, and it cannot replace human touch. Nothing can replace human touch. We have tried it, not possible, right? So AI is here to assist. Also want to say about the medtech sector master plan, which was established nationally in the beginning of the year. We were part of that group that put this together, supported in editing of this, and we are still continuing to work with the DDIC for further improving it. So this master plan aims at creating 3,000 new jobs. So there is future in medtech. Just in case if you're thinking about joining medtech or biomedical engineering, there is future, 3,000 new jobs. There is a big shift in regulatory landscape. Zazigona, a collective effort for the southern Pacific region, and SAPRA is effectively playing a big role in this. So there is hope for getting the technologies regulated locally. Also, would like to showcase initially we started science to science. Now science to society, we need to communicate our science to the community out there. So there is a podcast series that we run, and if you're interested in talking in these podcast series, we'll start with the Vice Chancellor, then we'll go to the dean. We'll be more than happy to have you. So there's some interesting talks from innovators to academics to young master students to PhD graduates. Feel free to watch this. And just in case if you're wondering, that's a moment when the president dropped Easy Squeezy down because he was trying to do the kids' reaction and he actually stripped it down. It was true. We have the video of him responding to that. But we also take conscious effort in actually taking our technology out there, to showcase our technology out there, to build our innovation, because we actually need to showcase that we are able to do these things here locally. It's very often people think that this is something of the West. When we go to forums, medical device forums globally, they ask us a simple question: do you design medical devices in South Africa or in Africa? Because there is a perception that needs to be broken, and this can be done only if we are able to communicate effectively on our effective, innovative solutions that we create out there. Thanks to all the my postgraduate students. I gave the number wrong, I know it is 8 PhDs, 40 master students who have completed. All these are the students who have completely graduated. This is my team who is currently working on various innovations. And master students, postdoc fellows current and past, and some of our staff. Many of all these staff are software staff within medtech. And I also want to say, last year I was due to do my inaugural lecture in September. So I wanted to note that date there. It was in September 2023, because of which I missed the inaugural lecture, and that was because of Professor Ramagondo, who put me to do that skills innovation challenge. But the good thing is, it's 1 year delay, but that's okay. We have got more success stories. But the good thing is, South Africa won gold in a space which has always been challenged by Chinese. We won gold for the first time in the big celebration. That's the deputy minister who was looking at some of our innovations. We do enjoy ourselves with good food. If you can't see that already, we enjoy ourselves. That's us celebrating Heritage Day. Always there's lots of food. That's a chicken, right? And that's one of our tech transfer office colleagues who we told them that they need to dress up in their first letter of their name. His name is Philip, and he dressed up as a parrot. And he won the competition. We enjoy ourselves with a lot of food and good things, because innovation, we need to express ourselves. We also celebrate diversity. Over the last couple of years, we've been celebrating Iftar. I'm not sure how many of you have been part of it. It's something that we are very proud of, because it actually brings all of us together. Those two ladies are the ladies there, Basia and Raisa, and we dine together. And we're all invited for next year's Iftar, if possible. We'll make sure that they serve good beer. We got a lot of paintings, right? That's what I mentioned. That's great. But again, this is the question that I want to ask ourselves. So what? And who cares? Right? And I want us to reflect on this in everything that we do. So what? So what? I've done these innovations. So what? Who cares? Have I taken it to the space where it actually needed? Have I actually done enough to take it to cross that London metro train map to go to the other side? I think I want us all to reflect on that in our respective domains of work. So what and who cares? I think a journey without gratitude is a recipe for disaster. And I would fail in my entire thing that I've done so far if I don't acknowledge the people who have actually led me to do and inspire what I've done. My parents, Papa and Mama, who are both of them in hospital now. My dad is as Lionel mentioned, I don't want to go into details. My mother is taking care of my dad over the last couple of months, 2 months in hospital. She's been just next to my dad, taking care of her. And I want to acknowledge the hardships that they went to educate me. Right? I want to acknowledge that my mother had to pledge her jewels to make me study PhD. I ended up being the first PhD in my entire clan. Right? And it's something that I'm very proud of, and I'm not ashamed of saying it outside, because it's these hardships that makes us as human beings. Yes. That actually makes. I try to figure out where my nativity is. Betuanam is my village or Gram. That's my hometown where I was born. It's very difficult to find it on the map. I do feel proud that from Betuanam I'm able to come to Cape Town. And being here, it's onwards and upwards. Right? Yeah, that's good. My family. That's any guess for guessing who I am in that picture? All right. The proud person with a cigar in his mouth is my grandfather. Very unique character. But I want to acknowledge my entire family. My brother, Professor Sudesh Sivarasu, who's watching it online. My sisters, this is Sumia Suresh, and this is Suvita Johnny, and their extended families. And my sister in heaven, who left us many years ago because of ill health. Again, these are stories that help us to motivate what we're doing. And I would be a person, not even 10% of what I am, if not for this person, this man who's been behind everything, that is Professor Sivarasu. I want to acknowledge everything that you've done, sir. So I know that you're watching it online. Big thank you to you, sir. I bow in front of you for everything that you've done to me. So thank you for that. And just in case, if you want to read more about it, you can go to his. We just published a book for him. I edited this book called TLM of TLM, Triumphs and Legacies and Milestones of Dr. Talakotala Samarkin, and you can read it on the website. Thank you, sir, for doing that. And if you are wondering what an academic can do in a person's life, right? there's a lot that one can do, but we don't see it, right? But this person did something that you can actually see it now, which is this. Any guess for who this is? My father failed, my mother failed, my siblings failed, all of them asked me to twist my hair. I couldn't and I didn't. But this person made me twist my hair. So. I want to thank the UCT Vice Chancellor 2030 Future Leaders Program. Thank you everyone for being a big support of that. Vice Chancellor, budget permitting, even budget without permitting, please continue this program. And why I'm saying that it's a very good program, not just because they gave a lot of money, but it's also because it gave you the freedom that you don't need to worry about money to do research. It gave you that freedom of mind so that you can focus on, because one of the first things where we saw the real impact of this is during COVID. Because we had a lot of plans for doing unnecessary research, but then when COVID struck, everything became unnecessary. COVID became necessary. So everything was put on the back burner. We needed money to seed money to get things going. Vice Chancellor's 2030 Future Leaders Program was one of those things. So I'm really indebted for this program. So thank you for that, and I'm grateful for this. I want to thank my colleagues. I know Professor Kitwan is not my colleague. Yeah, you might be wondering why your image is here. But I will come to it shortly. I also want to acknowledge the contributions of Professor Daniel Douglas, Professor Ernesta Menkes, Professor Thomas France, and late Dr. Lester George. All of them have contributed significantly in my career. But why I've included Professor Kitwan in this picture is because of one simple reason. When I went for a very first International Medical Device Conference in 2012, right, many years ago, about 12 years ago, and I told them that I'm doing medical devices, and nobody knew what I'm talking about. They asked me which university you're coming from. Nothing. But the only thing they knew was Kit. So, Kit, Professor Wan, without your knowledge, I've used your name. Thank you for being that inspiration. But really, your work has actually inspired us to go into the startup journey, to the whole innovation journey, which you may never know, but you have inspired all of us. And why Professor Thomas France is because he writes my recommendation letters every time. Professor Reed Thompson puts it even on his introductory notes, so thank you for that. Professor Ernesta Menkes was the one who pushed me from associate professor to full professor, and Tanya Douglas, late Tanya Douglas, was the one who actually made me, who paid for my first international trip as an academic. Because I didn't have money to travel as a medical academic, and I had to go to an interview for a BBC video shoot, and I didn't have money. So I told this to Professor Daniel Douglas, and she said, "How much you want? I'll pay you the tickets, I'll get you the flights." And it's a bad coincidence, but that's Tanya's TED Talk. The image that you see behind is the leprosy glove that we developed, which she supported for me to travel to be part of. Thank you, Tanya, wherever you are. I want to thank my HODs who allowed me to be as part of this journey. Right? Let me start from the first HOD to the last HOD. Professor Laurie Kellerville, right? I told him, I invited him to this talk. I told him, I don't know if you remember what impact you made on my life. He said, okay, educate me. And what was that? It's because he asked me to sit in a course review, and then he asked me to bring my CV. And he went through my CV and he said, do you know that you are a senior lecturer in India? Why did you apply for a promotion? Until then, I never knew I can actually apply for a promotion because I was on contract. But he gave me the first tip for me to apply for the promotion, and that was his year of retirement. But he allowed me to express myself to go from lecturer to senior lecturer. But from lecturer to senior lecturer to associate professor happened in the leadership of Professor Malcolm Collins. Professor Collins, thank you for your leadership, and I especially want to thank you for what you have done in giving freedom in everything that I was doing. Okay? You allowed me to express my collaborations with biomechanics, my collaborations with sports science. I want to acknowledge that, and I want to say a big thank you. And my last HOD, Stella is still my HOD, but my last HOD that led to my promotion in an academic journey, Professor Sharon Prince, I want to acknowledge for everything that you've done to me, for giving me the structure, for giving me a plan to propel myself in my career. You know, I wouldn't be here if not for what you have done in my life. So thank you so much for that, and I want to acknowledge you and Rafi together for taking time to be part of this lecture. A big thank you. We have a lot of complaints about our leadership, but we never get to acknowledge them. So now it's an opportunity for me to acknowledge. Thank you for that. A big thank you to RCNI, Research Contracts Office. Many of them were supposed to be here, they're not here, but big thank you to you. So the team is there, thank you for that. I want to thank the Faculty of Health Sciences, Department of Human Biology, the Biomedical Engineering Research Center, the Division of Biomedical Engineering, for giving me the space and giving me the opportunity to learn under these, it couldn't have been better. If I were to restart, I would start exactly the same. Thank you for that. Thanks to all the funders. I'm remembering you with UCT being in the middle. Thanks to all our partners. Thank you, everyone. Here comes the best part of my life. She is such an amazing soul. You know, I didn't know I could love somebody so much until she was born. Thank you, Adide, for who you are, and thank you for everything that you keep me sane. Thank you. The human side of it is because of you. I want to thank my wife, my better half. Definitely my better half. She was one person who was with me in the lowest of my times. When nobody else was around me, she was the one who was with me. So Abhi, I want to say how much I appreciate you, and I really want to acknowledge your contributions, and really want to say, you deserve, all the blessings of this life. So thank you very much for doing that. If you're wondering, that's the day I got married, the first picture. That's the day that I got promoted as a senior lecturer, and my wife was there during that time. And you used to host a promotions party, dinner party. That was the memory there, and that's the day when she's pregnant. She gave me a gift for my birthday. I also want to acknowledge my in-laws, because they have supported me when my child was born in India. When I was here working very hard, my child was born in India. So my in-laws supported me through this whole journey. So I want to acknowledge them. But I want to dedicate all of this to my father in heaven. You might be wondering, what is this? And this is a picture from Jerusalem, and I had a chance to do a little bit of trip. And an empty tomb is there to prove my Savior lives. It's a hymn that I really like and love. And this is something, when I go out of this building, these shots were taken just outside the building or coming into the building. When I look up to the mountains, where does my help come from? My help comes from the maker of the heaven. I want to acknowledge my Lord's presence in everything that I do. And I take this as my purpose in whatever I do. So thank you, Lord. I'm grateful for those who paved way before me, like the professor once. The path that is still unfolding before me, I still don't know what my path is. I'm still figuring it out. And for those who will continue the journey after me, the whole of MedTech and beyond, I'm grateful for all of those who are going to take this journey further. And as Professor Lyle also mentioned, it's just a celebration of one point in another. There's a long path ahead. And somebody said decades and decades. No, I'm not decades and decades old, I'm just 28. FrugalBiodesign, contact details. This is... if you're wondering what that is, visibly happy about the work that you're doing. You can see to the smiles. Let's be thankful you can. So that I would like to say a big thank you.
I was supposed to say good afternoon, but I think we moved on the program. But as we heard from Professor Mashabela, that this is probably the most important day in his life, his inaugural lecture, and I think a bit of overtime is not unreasonable. So, Abby, Arja, and Sudesh, Professor Mashabela, Professor Ramagunda, Professor Lana Bean Thompson, Robert Shanley, colleagues and guests. UCT's vision for 2030 was unleash human potential for a fair and just society. And hasn't Professor Sudesh Sivarasu just done that? He has been lighting that fire since his arrival at UCT nearly a decade ago. I would almost go as far as to say it has been nuclear. It is just incredible what you have done in such a short time. But as we've already heard, he's been lighting fires ever since he was young. He managed to burn down his house nearly on 2 occasions when his father's work at once. We also heard today that a promotion to a full professor requires meeting several requirements, such as teaching, social responsiveness, etc., which we've heard about. But there's nothing regarding the person that they really are. And I will give you some insight today. It will be about 8 minutes, so we'll be eating soon. So I stand here with immense gratitude and admiration to acknowledge the remarkable contributions to UCT that you have achieved. In fact, these contributions are not just to UCT, but South Africa and to the world. My gratitude extends to the invitation to give you this thank you response as we celebrate your inaugural lecture at the Professional Biomedical Engineering. I've asked several people what am I supposed to say at this thank you response, and it's been rather sketchy, but there goes anyway. I'd like to thank you to come to watch cricket at Newlands Cricket Grounds many years ago, and that's why you applied for a job at UCT. It must give you great joy to see the South African version of the IPL up and running in South Africa. Next, I would like to thank an orthopedic injury in guiding your life choices to get you here. After finishing his degree in engineering, he was given a fully funded scholarship to the UK to do an MBA, one of only 15 people in the whole country of India. Luckily for us, he was involved in an accident, unlucky for him, with his brother. He lay in hospital with a fractured shoulder and a fractured skull. This seemed to knock some sense into him, and he went back to and did not pursue business, although he didn't lose his business interests. There was mentored, as we heard, by Professor Matthews in Biomedical Engineering, which then followed up with his PhD. At this stage, I'll thank Professor Matthews again as he inspired Sudesh into rehabilitative engineering, which we saw today. This appealed to his social conscience, which we've heard about. I once asked Sudesh how come he had such leanings, and he told me the story of watching a patient with leprosy burning his hand with a hot cup of coffee. In India, they give it in a tin cup, and it's piping hot. This is how you answer your question, who cares? Next, I would like to thank his parents again, who sadly cannot be here today. They produced a great human being since I met in 2014. I'm not sure how we got introduced. I think it was Professor Walters. Well, he's been an inspiration. He always had a smile on his face. He's enthusiastic, compromising, but he can be a firm and a clear leader when needed to, with a huge emotional IQ. He gets things done, and he gets people to do things too. One of the most inspiring parts of your leadership, I see in the WhatsApp group, and I'm a little bit averse to social media, I'm a bit too old now. This is where I see the students and staff in your department showing each other respect, care, and recognition of their diversity. I can read out multiple students' comments, we've heard some today, about your inspiration and mentorship, but it would sound too much like a wedding. So, your CV and your production of graduates is a testament to this. But I thank you most of all in your willingness and ability to do all the administration work, which I hate, and you've managed to demonstrate today. I must commend on your willingness to take on responsibility in the runnings of the university at multiple levels like all your appointments. Back to your parents, Sudesh. They set you up for your success. Your mother as a teacher, who gave you a great start. Your father, initially a train driver, set up your engineering interest in mechanics and how machines work. He was lucky enough to come from Vellore in India, which is described as the destination for medical and technological research and the first translational stem cell research in India. Under your leadership, your department has experienced tremendous growth. You've expanded the capabilities, deepened the research, and diversified our community, making this department a home for students and staff from all walks of life. Your student-centered approach has fostered an environment where students feel supported, motivated, and encouraged to push the boundaries of their potential. You have consistently shown care and commitment to your colleagues and students alike, ensuring that everyone is valued, heard, and empowered to succeed, as you saw. Your journey has been nothing but inspiring. Over the years, you've not only made groundbreaking advancements in the field of biomedical engineering, but your innovative research has earned you numerous rewards, both for scientific excellence, innovation, teaching, and commitment to social responsibility. These awards, as I've said, are not only from UCT, but national and international. They speak volumes about your dedication, not to the lab, just to the lab, but to a greater social good. Your dedication to building collaborations, such as me and with many others within the university, has strengthened our department's reach and impact. These partnerships have opened new avenues for innovation and discovery, setting us apart towards even greater achievements in the future for UCT. I must caution at this stage that as in any good scientific paper, there are limitations which must be mentioned. As you heard, every time you bring a simple problem to the engineers, multiple questions and more problems are encountered. We still have not designed that shoulder replacement. After lots of funding. In addition, our IQ was challenged by his very clever engineering students, especially when collaborating with the computational mathematics science, who made the scapula a mathematics equation 8 pages long. We haven't used it yet. In addition, I have to keep my feelings of inadequacy under control, and I see the achievements and awards that you've had, especially when you're half my age. Maybe not my size, but half my age. Thank you for your leadership, your passion, and for the transformative impact you have made in the department and the lives of men. As we celebrate this milestone in your career, we look forward to the future innovations and advancements of your work, which undoubtedly you will continue to bring. I'm not sure I have the authority, in fact I'm sure I don't, but I thank you on behalf of the students, your staff, your collaborators, UCT as a whole, South Africa and the world for your contribution. And lastly, I thank your wife, who has come to South Africa and immersed yourself in our country by teaching French down in Rustenburg. Merci beaucoup. Congratulations, and a final thank you for allowing me to be part of the 5 years lived here at UCT. This is the end of the evening. A little long, but it's been fantastic. I think with everything you've done, it's actually very short. I'd like to say some brief thanks to the UCT and the Dean's office and all the staff who made this thing possible, the medtech students and everybody else for putting your inaugural lecture up today. Thank you very much.